I'm Dr. Mark Gold, and this is the Gold Standard. It is such a great pleasure to have Dr. Linda Cottler here for the Gold Standard. Dr. Cottler is a professor of epidemiology at the College of Public Health and the College of Medicine, and a former senior associate dean for research at the College of Public Health and Health Professions at the University of Florida. We've been friends, forever, and we'll get into that. So welcome, Dr. Cottler.
Thank you so much, Dr. Gold.
Yeah, it's really nice of you to take the time. And, as we try to do, we're going to go through big contributions you've made to the field. And I have too many listed. It's really quite remarkable. But why don't you just, if you would, just share with the audience just, your training and how it is that you get to be a dean and one of the most respected researchers in the field of addiction, substance abuse, and epidemiology at such a young age.
Well, first up, let me say thanks for having me. And I just kind of wanted to start off by saying how I got to this point. Because I started out, I was born in St. Louis, and I was just a girl from South St. Louis. I went to nursing school, and I knew there was something that was missing in my life, and I wanted to do something else, and I really threw a dart at a map, came up to Farmington, Connecticut. I didn't know anything about Farmington, but I'd heard of Boston. So I put everything in my car, moved to Boston, got a job at the Boston Collaborative Drug Surveillance Program, which later became the Sloan Epidemiology Unit with Boston University. And the reason I got it was because Alan Mitchell was a person looking for someone to do a coordination job for drugs of abuse in pregnancy, women who were pregnant. And he had gone to Washington University. So he thought, okay, well, this person is from WashU, I'll give her a chance. So I really enjoyed the whole thing. I got to learn all about drugs and the teratogenic effects of drugs and coordinate interviews. And then, so serendipity has really played a big part in my life, as it has for many people. And I met the guy next door in Boston. And so we got married, had our first daughter, and we wanted to move back to St. Louis. So I was told by a professor that there was a woman who was looking for a coordinator for a landmark study. And that was called the ECA study, the Epidemiological Catchment Area study. And so Lee Robbins interviewed me and offered me the job. So I coordinated the St. Louis part of the ECA study. And that is really how I got into epi and addiction science. That's how I got started. She told me that at one point she was not going to write any more grants. And so I just jumped in and I wrote 2 at the same time and got funded. And since 1988, I've been funded ever since from the National Institute on Drug Abuse. But Mark, I really enjoyed listening to your podcast with Dr. Chuck Zarumsky, because he was my chair, as well as Sam Guzay. I feel like, he really described the Department of Psychiatry, but he did leave out a huge part with Lee Robbins. And I was so proud to be part of that department and to work with Lee, because she taught me so much of what I know.
She taught a lot of people. I mean, when you think about her contributions, maybe I should focus more on you, but you might summarize them. I always think about the Vietnam experience and the role of environment in addiction. When I think about Lee Robbins, I often think about addiction and the role of environment, but there's many, many more contributions. You could just rattle them off so everyone knows what they are.
So Lee was a pioneer in psychiatric epidemiology, and she worked with Jerry Jaffe on a Vietnam study. They wanted to know if the men who were addicted to heroin in Vietnam, when they came back, would they still be addicted? And she really showed the effect of the environment, and that people could be treated and they could definitely be less, the exposure wouldn't be as strong if they were back here. So it really worked out well for Vietnam era, the veterans, and for the field. And so she was also very instrumental in assessments too. She knew the art of writing questions, and she taught all of us how to write questions, how to develop a questionnaire. And she also taught us that if something didn't seem right, it probably wasn't. So that's something that I teach my students too, that you have to look at the data. You have to really look at it, know the basics. All the fancy statistics don't really mean anything if you don't know the basics. And that was Lee's big thing. She
I
also
love that
taught.
study, by the way. So, you know, when in my career, people often said that opioid use disorder, or opioid addiction, as we used to call it in Lee's time, was almost always fatal, that the user continued throughout their life, that they were doomed in essence. And her work threw a wrench in that and said, well, no, if these guys move from Vietnam back to the United States and the war is over, they could come back and have normal lives. That's pretty remarkable.
That was remarkable. Yeah, they weren't doomed. And she taught all of us the importance of really looking through the data, looking at things and trying to figure out what is the most important thing. She was the so what question, asker. Like people say now, so what? She would also say, so what? So if you're not doing something that really matters and means something, then it's not going to have, you're not going to have a contribution, So that was important.
Well,
And
there's probably a lot of your career that I could relate to that, but you have like big footprints in a lot of different areas. So if you just look at her contribution, we start there. I could get to you and what is addiction? How do we develop scales for assessment? What is outcome? But let me just start with, I like numbers. So I looked and said, what's Linda Cottler's number one cited article? And it turns out to be with Sandy Glassman. Like, how does that come about? I mean, you have the number one article, and it explains a lot of dual disorder for cigarette smoking or nicotine dependence and major depression. And right now, when you look at the current smokers, I mean, the majority of them, it seems to me, have a concurrent psychiatric disorder, and you pioneered that whole field. Like, how'd that come about?
well, Sandy was not involved in the ECA study, but he knew that the Washington University group had the data on tobacco use disorder. And he called one day and he said, I would really like to know if we could analyze that data. At that point, there were a lot of people clamoring for the data, and we wanted to know who was going to do what, and everybody had to have a whole list of things, everybody sign off on it. But no one had claimed the nicotine and the smoking and depression topic. So it was our pleasure to go ahead and let him help us with the analyses for that. So that's how that came about.
Yeah, I mean, if you added depression and schizophrenia, who else is smoking right now?
Who
I
else
mean,
was? I'm sorry,
who's
Mark.
smoking after people with concurrent depression or schizophrenia? Like, you do have vaping exploding, and I bet you have some ideas about that. as we're creating millions of nicotine-dependent vapors.
Yeah, well, the thing about the ECA that was very interesting was for the first time we got to know about comorbidity. We didn't know anything about it before that. So we could see that did these things really go together? There had been studies before that had said people who drink were most likely to also have antisocial personality disorder, but we didn't have any idea about how mania affected the disorders, or how people with schizophrenia, what kind of comorbidities they had, how they smoked heavily. So that was one good thing about the ECA, and it brought so many theories to light and gave people so much opportunity to learn more about the age of onset and the progression and trajectories from one disorder to another.
Yeah, I put that in the top list of your accomplishments, and they're in the top 5 of your publications, ECA data. But one part of it that maybe you don't even realize is in the top 10 is the whole behavioral addictions. And as you know, I spent a lot of my career on behavioral addictions related to food, but
Yeah.
you pioneered the ECA data related to gambling, which is now in the DSM, thanks to that kind of work. Could you go through that for me?
Oh, that was very interesting. I think it's interesting that you bring that up. Again, because of Lee and because of some of the ideas that she had, we were one of the only sites to include pathological gambling disorder in our ECA. So I had a student, and she worked with me closely on different comorbidities. And we talked about it, and I suggested that that would be a really good topic for her to look at. So Renee Cunningham Williams, she took the lead on that paper, and she analyzed the data. First of all, we didn't know anything about the prevalence of gambling disorder, and it was like 1.2 or 5%, 1.5% in the population. But there were also, so gambling and post-traumatic stress and drug use disorders, those are all conditional disorders. They're conditional on having an exposure. So you can't have a PTSD or a gambling disorder or a drug use disorder unless you've used drugs or you've had a qualifying event or you've gambled. So there are these risk factors for the exposure, as well as the risk factors for those who go on to develop the disorder. And so that's one thing that I think is really interesting. So because of that paper, at the time, that was, maybe 26, 27 years ago, there was an idea we should really have some kind of a group of people around the country who are really thinking about pathological gambling disorder. And at the time, there was a National Academy of Science group that was looking at risk factors for gambling. And so I got to be a part of that group. And from that, there was a spin-off called the National, National something on responsible gaming, the National Center on Responsible Gaming, which then became the International Center on Responsible Gaming. And I was asked to be the chair of the Scientific Advisory Committee back then, and I'm still the chair of that Scientific Advisory Committee. And why that's important is because we want to do something different than the tobacco industry. That is, we want to look at the data to find out what we can do to find more prevention, intervention, understand more of the risk factors for gambling and gambling disorders. And so when a casino or when an industry donates their money, that goes to one group of the advisors, whereas we are the scientific advisors, and we have a very strict firewall between the two. So we don't have any influence from the industry. And that's how that's come about from that paper 27 years ago.
So if we go off on a tangent, I was going to do a whole thing on Lee, and then you're kind of, she was your mentor, but you've had already some great mentees. Wilson might be one, and he's got a bunch of papers with you as well that are in the top 10. Um, but rather than that, let's go off on a tangent for a second and just say, like, let's try to find out everything you know about gambling that might help people who are listening. Like, do you think teenagers buying lottery tickets is a gateway event for gambling disorder, or playing or having betting on sports or any
Yeah.
sort of video gaming? Give us
Yeah.
your point of view about what are the preconditions for gambling disorder?
So I don't think there's a lot of teenagers buying lottery tickets. I think there's a lot of teenagers doing sports betting. This happens in middle school too. So we work closely with a middle school here in Gainesville. And I don't know, some years back, we had them to decide what would you like to do a survey on. And they said they wanted to know about videos, video use among their peers, and screen use, and what I would call, gambling, precursors of gambling. And so they did that, and they found really high rates of screen use around video games. And so I think this is how they get into it. They all, it's not a thing that they do by themselves. They do it together. And then it just becomes something more. And then they get into points, and the points then eventually become money. And so they do get into the whole betting and the gambling, what we would call gambling. They don't think of it that way. But it is not only a time-consuming event, it does have some addictive potential, as you know. There are behavioral addictions, and you've done work in eating disorders and sex and other things. And I think that this is just one of those behavioral disorders that we really have to be aware of. And we have to teach parents to help their children to understand what they're spending their time on.
Yeah, I mean, your work has really helped me there. So, I've written a piece about total video time, and total video time doesn't really correlate as much as attachment. So you have some people who spend a lot of time and even develop a caffeine use disorder as part of their video gaming.
Yeah.
And then their games are gamified to look like video gambling. There's tokens and awards, like you said, and in some of the countries, especially in Asia, kids might go to school with their game score on their uniform clipped because they're so proud of it. And then, so now that we have cell phones and you can sports bet and you can watch pornography and do all kinds of things, do you see a day when drugs will be replaced by electronics?
I don't think we'll ever come to that point where there'll be total substitution and replacement. I don't think so. We just keep on putting more and more badges on the wheel. There's just more and more things to be addicted to. And it's very interesting because I feel like our work is never going to be done. Don't you think?
Yeah, I would say I think that the society is set up to stimulate people to repeat behaviors or to repeat choices. And that is how we define the total addressable market. That's how we get repeat customers. I mean, it was the easiest thing I ever really did was to work with the Yale group and then the Princeton group on food, because they were showing that sugar was self-administered by lab animals. And I'm saying, well, of course, I mean, if you're in a for-profit environment, who would ever want to invent a food where you wouldn't take it again? So I always harp back to the old Frito-Lay commercial and the saying, I bet you just can't eat one potato chip. And so the idea that we're increasingly trapped by our primitive reinforcement system is very compelling to me. And has served to me as probably that's why I've spent so much time on primary prevention in my career, because I see the others as a never-ending struggle.
That's true.
So, you also, I was going to say your mentees, but your mentees and you looked at how psychiatry influences outcomes. And I'm very interested in this. And my most recent Psychology Today column is actually focused on this whole idea that you can somehow treat someone without treating the whole person. And you could ignore major psychiatric illnesses and substance abuse and not expect them to relapse. And you even gone a step further. You've done comorbidity, but also even childhood victimization and trauma as related. So I know this is a big mouthful and you'll hate repeating it all, but you're probably better than me in summarizing this and look at both the psychiatric comorbidities important, the failures of modern day addiction treatment and ignoring that, and then the preconditions for addiction that you've defined in some of your classic publications.
Well, I think we have to be really careful when we look at the literature, because a lot of people don't think about the methods. I'm really a methodologist, and the research design is totally important to me. It's all about the questions and how you ask them. And it's about when you're asking. Well, for one thing, I believe in self-report. A lot of people don't believe in it. But I really do criticize when people say, oh, well, because of its self-report, we have to be careful, recall bias. That's true. We have to be careful. But we also have to believe people, and it's the person who's interviewing the person that makes it so important. If you're a clinician and you have power over the person and you're asking them about their trauma as a child and their drug use now and other things, they may be hesitant to answer you. But if I'm a stranger to that person and I'm interviewing them, there should be no reason people won't tell me things. And they have told me a lot of things, a lot of bad things that they've done and a lot of bad things that have happened to them. So I think that there is a great power in understanding what's happened as a child, what's happened in the teenage years, what's happened in the early adult years, and then in the middle years and the later years. So I do think we have to look at all of these things, and we have to think about the psychiatric disorder component about ages of onset, as well as there is some misclassification, there is some there's some bias in what we remember. So we do have to find the ways that we can ask the question so that people will reliably tell us about things that happened to them when they were younger, so that all of our analyses will not be biased, will be the best that they can be. So, especially about the trauma questions and other questions we're not allowed to ask some people, like about their history of use of guns, or if they're exposed to guns and gun violence. Sometimes we're not even allowed to ask these questions. So there are some biases about the data and the analyses that I think we have to be careful.
If you take your work, and like, let's say you have early exposure to trauma or gun violence, what does that mean as far as addiction liability?
Well, there are people who are just in those places to begin with. So it's a confounding variable. So they're in an environment where they were exposed to guns, they were exposed to violence. And so the fact that they're using drugs, is it because of that? Is it there a causal association, or is there an association that you would expect anyway?
That's
So
a
we don't know.
that's a funny one. So that's a Herb Kleberism, and maybe Myrna has picked that up too. So Herb used to say when we would evaluate a neurosurgeon who became opioid dependent, that you would expect him to have the most psychopathology, but a person who came out of the inner city in New Haven, you might think that they had sexual, physical, emotional trauma, violence, and so forth, and not think that they had any extensive other comorbidities.
Yeah. And if they've lived with something their whole life, they have the kindling effect where they're not going to be affected by something. So maybe they're not affected by it. But also, if they're in an environment where they're exposed to the drug or exposed to something, then they are more likely to be, a case. They're more likely to have the use disorder if they've used. There's so much more that we don't know, but it's also got to do with the research design and the questions that we ask and when we ask them.
So that's just fantastic. So, I mean, I'm not going to be able to cover your work on global prevention and global addiction issues, and I probably won't get to Health Street, but I might. But let's go to the National Drug Early Warning System, where, like you've established this, many people in the field have questions about the University of Michigan's data for reasons that you suggest, their paper and pencil, but I always like them because they're longitudinal. Nevertheless, your early warning system is built to last, if you ask me, because you piece together people at the grassroots, people who know what's happening in their community, and people who want a healthier community. So they are biased toward health and wellness. They're concerned about things happening in their community. And somehow you've pieced them all together into a alarm network, maybe like your version of Dawn. Could you just describe this?
Yeah.
Thank you.
I'm so happy you asked about NDEWS. It is the culmination of so many dreams of mine. It's my favorite project ever. And again, it's funded by the National Institute on Drug Abuse. And it is supposed to be the National Drug Early Warning System. And so when we developed it and we designed something where we could really break down all these gaps in knowledge, because the data we can have access to, the traditional data, are so lagged and they're old. And we had to find ways that we could quickly make them fresh. That's one thing that Nora Volkov, the director of NIDA, talks about. We need the freshest data. So we came up with a lot of different ideas that we could do. Number one, we have the rapid street reporting part of it, which is where we sent out graduate students. Again, one of our aims of this project is to teach people how to do surveillance for the future so that this does not become a lost art. Because with AI, there's so many people who think AI, artificial intelligence, can just take over and can replace what we're doing. But we're trying to show that we need to get out on the street, get our fingers on the pulse of what's happening. And so to make it a training experience, we send out the graduate students on a weekend, and we have 17 different Sentinel sites. And we go to those sites as well as other sites that might be hotspots. So for example, let's say we're going to St. Louis, Missouri, and we just came back from there a couple of weeks ago. We'll send 2 of our students, and we will pair them with 2 students from St. Louis that our Sentinel site director also told us about, so that we can teach their students also. So we've got these 4 students who are out. We come up with places that we think that they should go. So if there's a Cardinals game, they'll go down to Busch Stadium. If there's something else going on, they'll go different places around the city. And they go on a Friday. They stay all day Saturday. They come back in Sunday evening. So on those hours, there's about 30 hours in that weekend that they're on. They will interview people, and it's anonymous. We don't know who they are. They just interview people. It's about a 7-minute interview. And we cover as many drugs as we can. We cover all the drugs that we could possibly cover, everything. And the people tell us yes, no, if they used them or not. And they get paid a $2 bill because we don't have the money to pay all these people. But people are very interested in a $2 bill. So we give them the $2 bill. And now we're going to start with their saliva. So we can take the saliva and we can now compare, do the concordance between their self-report and what actually we find in the toxicology. That's one of our issues right there. And from those 30 different sites we've done all around so far, we have found such amazing consistency in our results. The number one drug, forget about nicotine. Number one drug is alcohol. So forget about alcohol.
That's in the United States. The 17 the major sites are every major city, really.
Yep. So we've done this about 31 times. We've gone out. So we've got recreational use of marijuana is number 1. Number 2 is psilocybin, shrooms. And number 3 is medicinal use of marijuana. And then after that, we get into maybe MDMA.
So one in 3 are marijuana.
Yep. And then we might get into some MDMA, some cocaine. But shrooms is always number 2. And it's unbelievable that there's so many people who are using psilocybin. So that's one of the things that has been really interesting. And we ask about side effects and we ask about their sentiment about use, but it's about a 7-minute interview. That's it. And they go out, they interview maybe 250, 260 people in a weekend. And then, it's all done on iPads. So that's one of the spokes of the wheel of NDEWS.
I'll ask another one.
Sure.
Let me ask you. So another spoke, and the one that I'm the most envious that you set up, because I was there when Bruce was recruited, is bringing the coroners into the picture. Yeah. So if somebody's dying, you know about it.
Yeah.
Well, yep. Who else knows?
Yeah, they know. So we have a network of networks, and we decided we needed these networks because we have questions that come up and we want to send them out every month to these different networks. Our networks include toxicologists, coroners, medical examiners, funeral directors, superintendents of schools, and reporters. These are all the networks that we're, involved with. And we send them questions that we come up with, and then we don't always get answers back from everybody, but we'll get a sizable number of responses, and that helps us to harmonize the data that we're getting from the RSR, the Rapid Street, and our other things, which becomes also our biospatial, our 911 dispatch data. So we're hooked up with biospatial, which is part of the NEMSIS program, which all the emergency departments are hooked up to. And we have data from about 43 different states. 75% of that data comes back to us in 24 hours. So we have fresh data on what's going on. Now, the limitation is that these are the ideas of the dispatchers, the EMS people. They have to talk to the people on the ground and ask, what did they use? What was going on? We don't have a test that says, yes, this person was using fentanyl or an opioid, but they're giving naloxone. And, so if there's a response, they say that this was an opioid response. So we look at fatal, non-fatal overdoses. We know the time of the day and the day of the week that this occurred. We look at the top 10 counties every single week, and we look at the rate per 10,000, and we see clusters of places around the country. So what? So what do we do with it? We have another group of students. These are undergrads who are in the honors program who want to, get credit for things, and they think this is a kind of a cool project. So they'll call up the departments of health from these counties, and they'll talk to somebody there, and they'll say, did you know that there was an overdose that alerted our alert system for last week for whatever it is that we're looking for that week? So it might be fentanyl, it might be heroin, it might be MDMA, it might be anything we're looking at. So that's another thing that's also teaching students how to get involved with the departments of health. And the other thing we have is our Reddit. So we have a collaboration with Florida Atlantic University with their robotics unit and their artificial intelligence program. And we have students there who are working with us, who are combing the Reddit data every single week, looking for different signals. Now, for that, the limitation is we don't know what the zip code is. We don't know where they're from, but we're hearing different things from different people about specific drugs. And we pick that up, and we always have that in our weekly briefing too.
Yeah. So, I mean, if you looked at that, like for the people watching, your group alerted everyone to the adulterants in opioids. Like,
Yeah.
wouldn't you say that's pretty close to, I mean, maybe there was something on TV about the zombie apocalypse, but you actually had what was in opioids that are being sold on the street.
Really hit the mark with a lot of drugs, and especially xylazine, medetomidine. We have really, had our fingers on the pulse of that for good reason. And now
you like developed
discussions.
You developed that field. So basically, they're adulterants. They're added in part because they have clonidine-like effects, and they're sedatives, and they potentiate, if you will, the opioid effects. By the way, when we gave clonidine for opioid withdrawal, we would wait 36 hours before we would treat them with clonidine. Like, where here they use them with opioids. So of course people are obtunded, but you developed that. Your group also, I think, has really helped everyone understand that there's such a thing as ketamine use disorder. Here we have psychiatrists using prescribing ketamine, but there are also infusion centers and at-home ketamine. And I think your paper is the paper that defined what is a ketamine use disorder.
We had this data from, all of my years of work with NIDA with reliability and validity, DSM and ICD criteria. And because we had the substance abuse module assessment, we had data on 13 different classifications and categories of drugs, and one of them being ketamine. So Nicole Fitzgerald, she was a graduate student of mine, doctoral student. She said, can I look at that data? I said, please look at the data, look at the reliability of the data. So she did the paper on ketamine use disorder reliability. And those are things that are just, not many people are really into the nosology, but our group has always been really excited about it. And it's because of Lee introducing me to the world of the World Health Organization, Norman Sartorius and those people, that I really got so interested in the nosological differences between the DSMs and the ICD, and got to work on the DSM 3R and 4. And it was just wonderful working with all those people. But it's something that's in me that I really, really want to know. What are the differences between these different classifications? What makes up a use disorder? Do we need all these criteria for the withdrawals, syndrome? What should it be? People sometimes just picked out of the air, but we have actual data. And also, should there be 2 criteria? And should there be 3 criteria? What should be the number? It's the seesaw back and forth. What is it that matters? And we were able to contribute to that, which is something I really love.
Yeah, I mean, it helped me a lot. Even the DSM-3R, you might remember that I was presenting data that cocaine was addicting, because in the DSM-3 it wasn't, and I objected to that with and I brought all my data, and everybody's going, well, that's not really controlled. It's patient reports to 800 cocaine. I go like, well, it's 400,000 patient reports.
Yeah.
Like,
yeah. Yeah, I remember when I first met you at Grand Rounds at Washington University, and you showed that video of the monkeys going to get the alcohol. And just, there were so many interesting things about that video and about the presentation you gave. And then, of course, we got to go out for lunch, and we really solidified our relationship and had so much in common about the field. It was just so refreshing.
well, I mean, you're not just a theoretical epidemiologist, and you're not just a scientist. I drove in the car with you. I think it was a Volkswagen when you were delivering condoms and working on
Yeah,
HIV prevention.
yeah. There was a convertible too.
Yeah, I was petrified. The like where you were driving and your sense of safety in the middle of all of it was just
Yeah,
remarkable.
it's great.
You spend a lot of time at WashU and at the kind of golden era of psychiatry and the golden era of WashU, and things
Yeah,
have all there's centers of excellence all over the place, but you've managed to bring the best of that to Florida and continue your work. I don't think there are very many funded investigators at the University of Florida at your level, if any. I remember trying to recruit you and having people tell me this or that, and it was all wrong. But mostly because people don't understand addiction research, people don't understand epidemiology, and they also don't understand that there are these just high integrity superstars, and investing with them gives you a chance to be great. So I'm really happy, of course, that I helped facilitate your move, because there might be nothing left of my legacy um, except for that. And I probably should change my primary affiliation to public health, because you and I have continued to work. And I'm so
yeah,
glad that you invited me to join your advisory board.
yeah. It's made a big difference. It really has. I mean, it's just been wonderful to work with people like you, Mark, work with you specifically, and to bounce ideas off of, because you are an honest person who tells somebody, oh, no, that's not what we see. That's not what it is. And it makes a difference because otherwise you're just getting people who say, okay, okay. But it's important for NDEWS. We can't be wrong. We have to be vetted. And this newest thing with 70H and with all of the
Kratom
kratom
and all,
issue.
yeah.
So kratom is one thing, but 70H is another thing. And we
definitely.
get information back from people, from our readers, a lot. They're really not very happy with us. But it's not just us, it's anyone who's doing research on kratom and 7-OH. They don't want people to get in their way. And so we get these nasty mails, but we need to be able to be correct when we write something. Just like with Psychology Today, you can't be wrong because it's going out to so many people, and people rely on us, and they tell us it's the first thing we open up on Friday, and so we really appreciate it, but we also have to be very careful. So just put in a
Your
plug.
service, like your newsletter, it's free, right?
It's free. It's
And
free.
so if people want to know what's happening in the United States or get early warning or get information, where do they sign up?
They go to NDEWS.org.
That's
And that's it.
NDEWS.
NDEWS.org, O-R-G. And you just go up to the top. It's in the right-hand corner. It says, you know, that you want to subscribe to the briefing. And you just put in your name, your email address, and we will start sending you the briefing Friday morning, 9 o'clock Eastern time.
So I've liked also the club drug work that you've done and your collaboration with NYU, where they have their club drug initiatives, and I've learned a lot from them too. Could you maybe just quickly review that too?
Sure. Joey Palomar is professor at NYU Langone Medical Center, and he is an amazing collaborator. He has been funded by NIDA to do club drug research. So he goes to the he goes to the clubs, and he's looking for whatever novel psychoactives people are using. And he tests their drugs. He tests, their saliva through Alex Kratowski's work in Philadelphia at the CFRSE. I don't ever remember what it stands for, but it's CFRSE, Center for Forensic Research something. And so Joey's been just a terrific collaborator. He is a prolific writer. That's basically all he does is sit in his chair and write papers. But he's always knows exactly what's happening in the field, and he's great. So we're happy to have Joey. We're happy to have Bruce Goldberger. Bruce has been terrific. We've worked together with Bruce. You've worked with Bruce longer than I did, but I've now worked with Bruce for many, many years, even on the Afghanistan project. It's just great to have someone who is so connected to the medical examiner coroner tox group. He knows so many things.
That's true. The Afghanistan project, that's been so interesting to know that there was second and third hand opioid use disorders possible. Yeah. I'm going to run out of time. It's just terrible. So what in the clubs right now, what would you say the number one drug is? Ketamine?
Probably ketamine. Of course, MDMA. Now we're hearing about stimulants popping up all over. So
yeah, cocaine is definitely back in Miami.
Stimulants, yeah. So it's really happening. Things are switching a lot.
Well, that's it. As a David Musto, one of my old teachers at Yale, used to say that every opioid epidemic is followed by a stimulant epidemic. And it's interesting that the stimulants are in a stimulant war. So you have methamphetamine being manufactured in that, mostly West Coast, and you have cocaine being grown. I once had a DEA trip to the coca fields, and they took me up the mountain in a helicopter, and you're getting shot. But the biggest impact for me on that trip was disposable submarines. So they had made so much money on cocaine, that they would load up these robot submarines with no pilot or anything, and maybe they use AI, I don't know. Then they send them to somewhere in the panhandle, some port that doesn't exist. But yeah, cocaine's back.
Yeah, yeah, stimulants are big time. But there's so much more to talk about, Mark. But um,
I just have to thank you. Say thank
I,
you for such a great career. Thank you for your work at WashU. There is no behavioral addictions if we couldn't have cocaine as addicting because it didn't have withdrawal syndrome. Your work has helped define psychiatric diagnosis. Your work has helped to reinforce the importance of treating the whole person and understanding trauma and understanding psychiatric comorbidity. And your work has changed the nature of trends and trend analysis because think about it, in Michigan, we'd get data 2 years after it happened, and you have data today that we could act on and save lives. So I thank you for that too.
thank you so much, Mark. This has really been great. Thank you for everything, all the influence you had on my life too.
It's a pleasure. Believe me, I'm very proud.